Are you going to treat that case once you have it in the practice? Or maybe it's better to delay the treatment? So in such cases, no, I will not bond the case. I will wait. And I will establish good habits. Lip seal, nasal breathing. On the other hand, if I have a class 3 with anterior positive over bite, which means I have a crossbite. So this should be treated once diagnosed because we have crossbite. But while you are discussing that with your patients, you need to remind them that they will need 3 phases of treatment. You will do phase 1 at the age of 9. Then we need to evaluate the case at the age of 12, 13 to see the need for phase 2. And in some cases, you need even to evaluate the case after the age of 16 to see the need of phase 3 because it's related to growth. It's not under your control. Remember, 3 challenges: sun, growth, unwanted forces. Okay? So this is my protocol. Again, what's missing in our profession is management. So we need to manage when to see our patients as consultation and when to start the treatment. So this will help you to have the right start with your patients. So this is for the timing. Now we know when to start the treatment. For the case selection, I would prefer to start with normal growth and the upper anterior teeth, they are not compliant, the lower anterior teeth, they are not compliant, we don't have dental compensation, and the patient can bring edge-to-edge bite. And we need to examine the patient in centric occlusion and centric relation. For example, if this is your case, is this orthodontic or surgical case? If we have a surgeon now between us, and this is his case, and the age is 24, what's the treatment plan by the surgeon? Concave profile, he will evaluate it as still a class 3 adult patient. This patient will need orthodontic surgery. This is the opinion of surgeons. But again, this is centric occlusion. So ask your patient to bite in centric relation. Are you going to do surgery for that profile? Of course not. So if you evaluate the profile in centric occlusion, maybe you'll go for surgery. This is wrong. You need to evaluate the profile in centric relation. So the profile is normal. So this is a recommended case quality. So let's start with phase 1 treatment. Younger children, once diagnosed, if you have positive over bite. This is Judy. She's 9 years old and she has anterior cross bite. She has concave profile and she has positive over bite. These are the intraoral photos for Judy. If this is your case, what's your plan? Are you going to bone brackets? I will tell Judy, look Judy, your dad will pay $1,000 for your treatment. So why not to help your dad to save some money? Why not use that tongue depressor 2 hours per day for 2 months? By this you will save $1,000. This is in front of the parents. So the parents will be more than happy to save money. So they will stay consisting or instructing Judy, put the tank depressor, put the tank depressor. Okay, we want to save money. Okay, and later on, after 3 months, we fix the problem. So if there's initial class 3, you can jump the by 10 depressors, and this is the same case after 3 years. So it was only 10 depressor, and no money was spent on the case. So make it simple. So this is in the 3 months, so 2 months, and this is after 3 years. So it was stable result. And it was reflected on the face. So she's doing well. That's why I'm moving her case till the age of 16. So this is within 2 months, and this is her profile at the age of 13, after 3 years. On the other hand, in Salma case, we are doing routine consultation as usual. So this is her panoramic X-ray. If you go back, do you see any class 3 not included? It's not related to the topic, but you see that later on, I mean intraorally. But let's start with the panoramic X-ray. This is your patient. Do you see anything abnormal? What's the red flag in that X-ray? Too many things. Number one, she has conjunctive missing 5. And what about the scanner? Compared to the right canine. So what you are going to do? Her age is 9. What's the most important decision to do by you as orthodontist or pediatric dentist? You have a case like this. 9 years, intensity of action of upper canine. What to do? Preventive extraction of upper C's. It's a must. Once you extract the upper C's, the percentage of self-correction of the upper canines may exceed 78%. So the right timing of early extraction of retained C's, see what will happen? We did that. You see the amount of self-correction. So you need to interfere in such cases to guide the teeth eruption. And I'm doing follow-up for hair bite, so this is hair bite. And that canine was erupted. She has a cross bite. I gave her tongue depressor. She didn't put that tongue depressor. So I told the parents we needed to put braces on her. So the mother told me, give her the last chance, give her the last chance. So I needed to add deep grammars on lower left lateral and canine. So she will bite on them like this. So it's minor cross bite, so no need for braces. Still, she's under follow-up. On the other hand, if you have a case like this, Yara, she's 9 years old, she's living in Dubai or Abu Dhabi, and they proposed face mask. Do you think children, they like face mask? By the way, what's the aim of face mask? Why do we need face mask? Why you need face mask? The face mask has no wireless, let's say, connection to the arch, has no magnetics, has no magic. It has only one function, to hold the elastics. So it's about elastics at the end. So if I can apply elastics using braces, why do we use that big, sorry to say, ugly device for our children. So they traveled all the way from Abu Dhabi to Jordan just to avoid face mask. And she has compared profile. She's showing the lower incisors, not the upper incisors. And these are the intraoral photos for Yara. She's 9 years old. And the upper arch is not constructed. That's why no need for any expanders. And we decided to help her. So we bonded her case. At that time, it was Demnic Q. So I flipped the retrocline torque. So now it's procline torque because it's flipped. I added deep parameters on the lower two centrals. I'm creating space for decanines. I'm applying buccal plastic elastics. It's better to use Bellator plastic elastics. And this is the day of bonding. And this is her case after 2 months. She traveled back to Abu Dhabi, then she came back. So we bonded the laterals. We are now in the Cersei wires. And I finished her case in 1 year. So now she is 10 years old. Then I saw her after 1 year. Now she is almost 11 years old. Then I saw her after 4 years. Now she is 15 years old. So it was stable treatment, just 5 braces. So the job of the face mask is this, elastic. So if I can use the procline torque of lower incisors as my face mask, why to use that extraoral device? So deep grammar, we shifted the bite. So from day one, she will leave the practice with edge-to-edge bite. So she entered the practice with complete profile. She left the practice with a straight profile. And within 2 months, we can jump the bite. Now we are in the Cersei wear. And like in class 2 cases, your braces, they can do space maintaining or regaining. And we finished her case within 1 year. The same patient at the age of 11, at the age of 15. So the case is stable. So that shift in hair bite in one visit. Hair follow-up visit after 2 months, Cersei wires, debonding at the age of 11, at the age of 15. And if you check her lateral staff, it was true skeletal change. Very comparable to the face mask that has only one job, to hold the elastic. We use elastic. So this is her case within 1 year of treatment, and this is her profile after almost 4 years at the age of 15. So even her facial features, they are improving. She's growing, she's happy, and you need to do even phase 2. And now she is showing the upper incisors, not the lower incisors. So it was good improvement. By the way, do you remember the effect of procline torque on upper incisors in class 2? It was proclination and intrusion. It's the same for class 3. So it will do what, because she is showing lower incisors, and now she is showing upper incisors. So the procline torque on lower incisors will do this. So again, it will do proclination and intrusion. So it will hide the lower incisors. So her case was treated using Demon Q at that time. What about Demon Ultima? Let's take Nahla. Again, she has complete profile. She is 11 years old. Her parent teeth, they are erupted, but I don't want to make the full comprehensive treatment. I just want to bypass the crossbite at that age. So I bonded her case using Demon Ultima. That's why you know the difference now. With Demon QQ2, you need to flip the brackets in the lower incisors. Low torque, if you flip it, it will be procline torque. With Demon Ultima, you don't need to procline you don't need to flip any bracket. And by the way, the power of procline torque of Demon Ultima not comparable to Demon Q2 or Q2. More powerful, and it's the best in the market. So this is the bonding session. We bonded her case using retrocline torque on the uppers, even the center was neutral, and procline torque on the lowers, and the rubber bands, they were balanced. And within one follow-up visit, we shifted her bite, and within 10 months, I finished her case without the need of expanders or face masks. Just early bilateral clustering elastics and anterior deprograms. Space maintaining and regaining. You can do overcorrection. This is the shape of my anterior deprograms on lower two centers. I'll try my best to push her case till the age of 16 to do the final hesitating. So you will shift her bite from a negative overjet to almost edge-to-edge bite from day one. And that treatment will be reflected on her profile without the need of any extraoral device or heavy forces. Big change in hair profile. If you want to have active retention and you want to establish nasal breathing, you can use the same theory of Rolf Frankel, functional appliances. So you can use my brace P3 in order to have the flanges pushing the upper lip while you are holding positive over jet. So you can ask your patient to use that device as a retainer at the same time. This will improve oxygenation and this will give you good effect on the muscles of the face. It is like Frankel 3, by the way. So this is for phase 1. So you can help your patients. And by the way, this is very good marketing tool for you, that you are not using face masks. Like Yara, they traveled all the way from Abu Dhabi just to avoid face masks. And we have a lot of children that they hate face masks. There's a problem with their confidence in life because of the face mask, even indoors. What about phase 2? Like in class 2, in phase 2 it's different story. Because you need to know what type of class 3 that you have. So, in some cases you will have pseudo class 3. So it's not the crossbite, it's collapsed upper arch. The upper arch is constructed because of missing teeth, impacted teeth, buccal displaced canines. In very, very rare cases you will have a true class 3 in which you have bilateral class 3. These are very rare cases, but most of your cases, they are class 3 subdivision. So the patient has a class 3 more on one on one side, and the other side is the class 1. So in these cases, I mean class 3 subdivision, you need to apply asymmetrical mechanics. I mean the force of your class 3 mechanics should be more on one side than the other one. Let's have a pseudo class 3 case. This is Dina, and you are good orthodontist. So you need to think about everything. Her age is 15. So she is not phase 2, and she is not phase 3. should I wait till the age of 16? We need to check everything. So she has constructed the upper arch. She has increased lower facial third. We have a problem of vertical growth. If you go to the case selection, she's not the right case because she has increased lower facial third. She has high angle case, and this will increase, and still she has a growth. But if you check the intraoral photos, she has constructed the upper arch, and the most important thing in her case is lower sexes. Lower sexes, they are badly distracted, bad filling, and we are not sure about their prognosis, even if you check their height. No crowd. And she has a pseudoclass 3 because of buccal displaced upper canines, so the maxilla is collapsed. That's why the maxilla couldn't include the lower arch. If you check the panoramic X-ray, both lower sexes, they have infiltrated with big fillings. Do you consider this a good tooth with good prognosis? Or poor prognosis? It's a poor prognosis. So even if you put the best filling, best crown, you will lose that tooth sooner or later. At the same time, we have the AIDS. We have wisdom teeth. So what do you think should be the plan? So orthodontics is about management for your cases, then good planning. What's the plan of such case? And it should be strategic plan. You are good planner. So what do you think we should do in such case? Should we delay the treatment or to do the treatment? This is the first question. Do it or delay it? Do it. Number one. Number two, are we going to bond both arches or one arch? One arch, the upper arch. Yeah. What to do for lower sexes? Extraction. Without any bonding for the lower arch. The teeth will have mesial drift. So she is high angle case, and the mesial drift will be farther in her case. And if we check the lateral staff, we need to check her profile in centric relation. So this is her profile in centric relation, and this is her profile in centric occlusion. So almost case selection is there. So we bonded her case, I mean only the upper arch, using the right tool. We allocated space for the canines. We are not using any class 3 mechanics because she is in a pseudo class 3. We included the upper right canine. Then I bonded the upper left lateral and included the upper left canine. Still we are in the first wire, by the way, which is 14. And all of that was enough to correct the crossline. So this is the right cochlear view. The grams, they were on lower 7s. I will not extract at the start because I was not sure that they will complete the treatment. So I want to bond the brackets first to make sure that she is a cooperative patient. Then I can do the extraction. So we did the extraction of lower 6s. You will have mesial drift of 7s, and the wisdom teeth, they will erupt at the site of lower 7s. We don't have now crossbite. All of that is in 2 follow-up visits. So you can see with me the amount of arch development in 2 follow-up visits. Still, we didn't insert the ultima waves. And for the lower arch, these are the degrammers. And before extraction, I removed them, and I sent her to extract lower 6. So this is her X-ray after extraction. With time, we have mesial drift of 7s. in 8. For the upper arch, I will not finish in ideal occlusion. I just want to bypass the crossbite and to give her a smile, accepted smile. Then I'll do debonding, so it will be very fast treatment, maybe 6 months. Then I will leave her by till the age of 18, once we have the AIDS erupted. Then I'll do the final phase 3 treatment. So it will be express, very fast treatment in terms of phase 2. Then we'll do phase 3 later on at the age of 18. And for the upper jet, without any class 3 mechanics, because the etiology behind her class 3 is collapsed upper arch. So in pseudo class 3, the maxilla is constricted because missing teeth, impacted teeth, buccal space canines. You need to do only arch development or space creation, and all of that will help you to bypass the crossbite. I'll do my best to push most of my cases, if they don't have crossbite till the age of 16, to do final phase 3. If they have crossbite, I'll do phase 1. Maybe you can do phase 1 only, then we'll do phase 3 later on for these cases. The most important thing with phase 3 treatment is the following. Is this number. 57. Is there any correlation between class 3 and 57? In 2 days, we extracted 57 wisdom teeth. In 2 days. In these 2 days, the whole practice will be shifted from orthodontic and dentistry toward surgery. And I have a friend, his name is Muhammad. He was dentist. Then he went back to the medical school. So he had dental degree and medical degree. He's so smart and skillful. He's doubly qualified. Then he did the general surgery and maxillofacial surgery. And now he is consultant in UK, in Leeds. So I used to book the flights and the hotel accommodation for Muhammad to come to my practice just for 2 days to do all extraction. And this is the team for the 2 days. I'm the referring doctor. And we have 2 doctors, and these are the assistants. So we used to accommodate 25, 30 patients in 2 days. All of the patients, they are leaving the practice smiling. No swelling, no symptoms, simple, easy extraction. Because the surgeon, of course, this is the surgeon. So, by the way, you know Ali? This is Ali, yeah. This is Rasha, my practice manager. And this is Dr. Dania, treatment coordinator, Lina, treatment coordinator, Ghalib, cosmetic dentist, Rahmi and Iman, orthodontic therapist, and the other team. So we used to do extraction of wisdom teeth in 2 days. So this is the most important thing to do for your class 3 cases in phase 3. You need to extract wisdom teeth. So in order to have that correction on your patients, extract wisdom teeth. Of course, we'll extract all wisdom teeth, but mainly lower wisdom teeth. That's why if you delay the treatment to the age of 16, you can take that decision. Then I'm going to apply bilateral class 3 elastics with anterior deep lower 2 centers. I will ask my patient to keep using these rubber bands at 24 hours. This will give you 3 effects. Number 1, This will do arch development for the maxilla. Number two, you remember the bunting effect? This will give you, I call it face mask effect. So you push the whole maxilla in the forward position to support the midface. And number three, remember, we have a fresh extraction side, lower wisdom teeth. So imagine if you do the extraction in the middle of the teeth. So you have fresh bone. So the distalization effect will be amazing. And we have procline torque on lower canines. So the roots of lower canines, they are not touching cortical plate. There is no anchorage now. So you do distalization for the whole buccal segment. But remember, in most of your class 3 cases, the midline is shifted. That's why you need asymmetrical mechanics. And the retraction, if you see that, for my lower anterior segment, it will be asymmetrical. You will need it more to one of the sides of the treatment. So in a class 3, phase 3, you need to extract wisdom teeth and you need palatal class 3 elastics. Let's go back for, now we have the right timing, we have the right patient, and we did the extraction, and we have the mechanics. And you know how to put the torque. So let's go back to discuss more about your phase 3. The third challenge is the unwanted forces of class 3 mechanics. And you know now what are the unwanted forces if you apply class 3 elastics. What will happen for the lower incisors? Lingual tipping with extrusion. How to prevent that? Procline torque with tabs. Number 2, already you have procline upper incisors. How to reduce that? Retrocline torque. This will support the midface. And number 3, while you are applying class 3 elastics, this is what will happen for the occlusal plane. You will have anticlockwise rotation or upward rotation of your occlusal plane. So the incisor show will be less while smiling. Let's see these unwanted forces in one of my cases. This is one of my old class 3 treatments. Muhammad, he has through skeletal class 3. He couldn't bring edge to edge by. He has deviated chin to the left. And if you see his frontal view, you see this, the canting, and the chin is deviated to the left. And he has umbilical spine, and the lower midline shifted to the left. I treated his case without surgery, without extraction, with the right torque, but I missed some of the unwanted forces. So if you check intraoral occlusion, he's good, except the extrusion of lower incisors, because I didn't add tabs at that time. And if you check his lateral sap, there's a good amount of skeletal change. We shifted his case from surgical case to another surgical case. And if you follow the movie on the right side, right screen, I need from all of you to follow the change on the upper lip and the mid face in that case. Follow the movie. It was a big change in his profile. He used to call the practice, told Dr. Badr that I have cheekbone. So he was the first one who giving me the idea of supporting the mid face because of his feedback about the cheekbone. So everything is great. Even the frontal view, you remember the deviation of the his chin to the left? Without surgery, without doing anything, just correcting the class 3, almost we restored symmetrical face. So everything was great. But let's go to his smiling photograph. So in terms of bite, lateral sap, profile, everything was great. But for the incisor show, this is what was happening for the incisor show. Do you see the difference now? Are we increasing or decreasing the incisor show? So the incisor show is decreased because we had anti-clockwise rotation of the occlusal plane. So while you are applying class 3 elastics, this is what will happen with your patients. Maybe you are happy with the bite, with the occlusion, but you will not like the smile. So my mission today is how to treat challenging malocclusions while you are improving the incisor show. So I want to do the two opposite things together. To do that, you need to have 4 tools. These are the 4 tools that I'm using in order to control everything in the class 3 cases. Number 1, you know it now. Variable torques, you know how to make the torque for class 3. Number 2, you need to modify your bracket placement. So where you are going to put your brackets on the centrals, you can understand. 5.5 or 6? Which one? 6. I want to put them more gingival. Thank you so much. And number 3, I need to modify my class 3 elastics to make them maybe with different pattern. And number 4, you need tabs. Distal to lower canines. And we'll have a case about each one of these tools. So for variable torques, all of you, you remember the torque selection for a class 3. This is your class 3 torque selection. So you remember Professor Day Abir, 50 years old, she was convinced that don't do anything, your case is surgical. So she spent her life convinced that no way to treat her occlusion or smile without surgery. And then at the age of 50 years old, her periodontologist told her, why not to take a second opinion with better? So when she visited me, and I told her that, no, I can treat your case without surgery, she was not happy. She was about to cry. Because she felt that she lost the most important years of her life with that smile and that occlusion. And she has to travel from Jeddah in Saudi Arabia to Amman every 2 months. And she has thyroid problem. She has to take thyroxine, so we don't have right for remodeling. So a lot of challenges, and you don't see her smile. She has constricted upper arch, reduced incisor show from the beginning, and she has facial asymmetry. Which part of the face now is bigger? Now you are expert. Do the face perimeter and tell me which part is bigger now, the right or the left? One of you said the right. Who said left? Yes, it's the right. But as I said, it's not easy to know that from the beginning. But in the binary, we will see the asymmetry. Let's see the intraoral photos. But before that, the upper incisors, they are proclined. Lower incisors, they are retroclined. These are the intraoral photos for Abir. The upper arch is constricted. All bad crowns. And we have retained C, retained primary canine between the parent canine and fold. So this is the day of bonding. I got the brackets at 6 millimeter. I'm planning to extract that tooth same day of bonding, but this is the photograph for the torque. So please take a photograph for your torque selection, your cases, before inserting the wire. That cheek retractor is the cheek retractor for bonding. Don't remove the cheek retractor before taking photograph for the torque selection for all of your cases. Are you happy with the torque selection? Yes. So this is the day of bonding, and we are applying now bilateral cluster elastics. And in the same session, I did extraction for the lower right C, the primary canine. So lower incisors, they are retroclined. We did extraction, and she is applying cluster elastics. If you are not using Demon Ultima, what will happen for lower incisors? They will go to sleep. But let's follow what's happening with her. So this is the day of bonding. She left the country to Jeddah, and we are doing the follow-up. Still, we are in the flexible wires. And after our fourth wire, we'll do detailing session, panorebo. So this is Abir with the panorebo. So which part of her face is bigger now? The right side. So you will see the canting in the detailing session. So you need to tell your patient that you have face asymmetry. You don't notice that. Once we align your teeth, you will see that. This is not because of our bracket, it's built in, but we will, let's say, uncover it, we'll remove any camouflage. In that session, I did the position for the upper right lateral, central, and lower two centrals. Now it's time to add tabs and a new pattern of elastics. And I'm doing, by the way, if this is your case, how to correct the canting of her smile? How to correct the canting of class 3 smile? In class 2, what we have done? We added one tab to do impaction. Are we going to do the same in class 3? No, because already the maxilla is deficient in the class 3. So if you do impaction, this is wrong. I need to do extrusion on the left side. That's why intraorally, I'm going to apply more intrusion on the lower arch, then more force of the elastics on the left side. Because I like the canted side, and I want to extrude the left side to correct the canting. I finished her case in 18 months, but remember, I spent the whole 50 time doing class 3 elastics. Lower incisors, they were retroclined, and we had extraction. What do you think now about lower incisors? You see them from the occlusal view and the X-ray. We maintain their position. And no bracket in the market can help you to do that, except Deon Ultima. So again, this is the right bracket view. This is the site of the extraction. Palatal class 3 elastics. You are not having procline torque. The lower arch will collapse because of the extraction and the class 3. The same on the left side. This is the upper arch. What's the most important tooth in the upper arch? What's the most important tooth in the upper arch? sevens. You need to bond sevens. They are the best reference or cornerstone for you to have the right arch form. These are the buttons for bilateral plastic elastics. You can see with me the amount of arch development. I don't like the old crowns, but she needed to change them after finishing the treatment. I'm retroclining the upper incisors to have bunting effect to push the maxilla forward. That's why you see the traces of the IBR. So retrocline torque of the upper incisors with IBR will do that function. I was not happy about the finished rotation of the molars, but again she is traveling and she wants to remove the braces. That's why I use finishing aligners. You see them now. But this is the amount of the arch form development in her case. All of that because of the kicking effect of the dermal ultima and the power of the bilateral plastic elastic without the need of any expanders. So your upper sevens, they are the cornerstone for the arch development. And I did some buccal push for the upper sixes and some rotation for the anterior teeth as finishing aligners. For the lower arch, remember, I can see the labial surface of their lower incisors. This means what? The lower incisors are retroclined. Add to that extraction, add to that plastic elastics. Of course, she has anterior tongue thrust, so I added tongue tamers. We are closing the space for the old extraction. We are doing asymmetric extraction to the right. And we finished her case. Compare the lower incisors before and after. Even after, I like them more. Even we have the extraction and the bilateral plastic elastics. So we have controlled space closure. Again, I did some toe in the molars region. I did some finishing for the lower incisors using finishing aligners. And remember, the upper incisors, they were proclined. Now they are normal, or even maybe they are retroclined. Lower incisors, they were retroclined. Now they are with better inclination, even with the extraction. So this is a good example about the power of the torque of the ultima. And this is appears before and after. Before and after. And you can see the change on the X-ray. So we supported the whole maxilla, and we put the whole maxilla in more forward position. Remember, 50 years old, traveling, she has thyroid problem. We supported her mid face, and we avoided surgery. All the doctors told her that your case needs surgery. And for the smile, you remember, we have canting. So in classic cases, I'm not going to do intrusion. I'm going to do extrusion using my lower tab. So this is her smile if you do that. So we have 100% incisor show wide smile without canting. So remember, we are discussing the tools to avoid the unwanted forces in the class 3 mechanics. Number one was the torque selection. So the torque was very effective in Abir case. The number two is modified bracket placement. Where to put the brackets in the class 3 cases? 5.5 or 6? 6 millimeters. So they should be at 6 millimeters. It's one of my patients, Hadid. Again, she is 46 years old and she had the same history like Abir. She's traveling again from Saudi Arabia, from the same city, Jeddah, and she had the same history. All of them, they told her that your case is surgical one. She has complete profile, and these are the intraoral photos for that patient. The interesting thing is the attrition of the incisors. So again, she was not happy because she told me that I want to go back to all dentists and surgeons and orthodontists who told me that your case is surgical case, to fight with them. So this is the day of bonding, and you need to be an artist orthodontist. The first thing to do in such cases is what? Build up, follow the upper incisors. I'm doing that myself. So I did freehand build up using flower composite. So this is before build up and this is after build up. So this is her case, before build up and after build up. I spent 1 hour doing the build up for upper incisors and upper canines and lower canines. You need to do that. She was tired, I was tired from the build up, so I asked the team why not to have 5 minutes break for Hadid. But while she is walking in the practice, I think that she's not the same person. There was a big change in her face just with the build-ups. So I asked the team, please, so this is her bite now. So she entered the practice with the reverse overjet. Once I did the build-up, now she has edge-to-edge bite. And all the muscles of the face, they are different. And even the color of the skin is different. So I asked the team to take a new lateral staff just after the build-up. Okay? So this is her lateral staff after the build-up. So only build-up changed the profile. Without braces, without anything. And even the soft tissue profile. Even the color of the skin. Do you see the mid-face now? We supported her cheeks here and here just by doing the build-up. And for her smile, she's not the same person. All of that in 1 hour. So sometimes you need to respect the teeth size. She was so happy. Even the color of her skin, it was anti-aging. So I bonded her brackets at 6. You will find something interesting. What do you see different in all of my bondage in this case? There's something different. I made it intentionally. What do you see? What do you see as something strange? You see the brackets on the centrals? Yes, they are at 6 millimeters. But what I did for the door, I closed the door. Why? Because I want to remember that in that case I put the brackets at 6. So this is my protocol now. If I put the brackets at 5.5, I will take the photograph while the door is opening. If I close the door, this means that I put the bracket at 6. I want that picture to give me all the information needed. I don't want to write down. So if you see any bracket on the center is closed, this means that my bracket position was 6 millimeters. One more thing. What do you call these? Black triangles. But we didn't start the treatment yet. So from where we had these black triangles? What's the etiology of these black triangles? Extruded. Because lower incisors, they have no stop. So they will extrude, and she's 46 years old. So lower incisors, they are extruded with time, That's why you can see the black triangle. So the black triangle was because of the extrusion of lower incisors. So if you put procline torque, what will happen? As we have said, procline torque will change the position of the teeth in 3D. So it will do proclination and intrusion. So the procline torque will help us, in addition to the IPR, to get rid of the black triangle. So remember hard tissue recontouring, build-ups, and to put the brackets as 6. Let's go back to the 4 tools. The last 2 tools, you need to change the pattern of elastics and you need to put tabs. The Sabria as example. He is 90 years old, and you can see with me the severe proclination of upper incisors and deficient midface. And imagine if you apply class 3 elastics, what will happen to the smile? You will have upward rotation of the occlusal plane, anticlockwise rotation of the occlusal plane, so you will reduce the incisor show while smiling. So I need to control that. We have almost complete spine, bilateral class 3, reverse overjet. It was a skeletal class 3, it was surgical one. What to do for the wisdom teeth? Remember 57? Okay, we need to extract them, so we extract the wisdom teeth. And this is the torque selection. If you want to change anything, this should be recline torque. So we bonded his case, bilateral class 3 elastics, but because he has severe class 3, I put the rubber bands from lower force. We put the brackets on the centrals. The brackets on the centrals, they are at 6 millimeter. And because the overjet is too big, I mean the reverse overjet, I added my deprogrammers on the buccal cusp of lower right 7, lingual cusp of lower left 7 because of the crossbite. Then later on, we reduced the amount of reverse overjet, so I shifted my deprogrammers to lower 2 centrals. We continued the bilateral class 3 elastics. Now he is in edge-to-edge bite. When I do Banoribo, for example, I did the position for the upper right central, upper left lateral. I will mark the door of the bracket with the original torque. So I can remember that I did the position for these teeth with that torque. Now we bypass the crossbite. But again, maybe you like the bite, but you need to remember the drawbacks. So we have some sort of extrusion of lower incisors, and we have anticlockwise rotation, the whole occlusal plane. So we need to control now the class 3 mechanics. So we added 2 tabs instead to lower canines. I'm applying something, I call it anterior triangle class 3 elastics. And we are correcting the class 3. Now almost we are in class 1. This is the right buccal view. So he has severe class 3. So I couldn't apply class 3 elastics from the canine. It was from lower force. At first we put the deep grammars on lower 7s. Then later on I can add them on the lower 2 centrals. Imagine this is his bite, huh? This is his bite. By the way, he's overweight and so big. So I thought that this will give him the chance to lose some weight. But no, still he's overweight. And when he sits on Blamika chairs, you know Blamika chairs, they are compact, small. Huh? Even if you put that chair in the extra position, once he sits, the whole chair will do this. So he is so big. Now we are in the edge-to-edge bite, in the binary position. Later on, I can apply the class 3 elastic from lower canine. Then I needed to control my class 3 mechanics. So if this is a clock, what will be the net result of my forces? I mean, this board chain, this vertical elastic, and I added deep grammar on lower 7. So what will happen for the whole dentition? You'll have clockwise rotation or anti-clockwise rotation. What will happen? Clockwise rotation. Is this going to support the midface more or less? More. And for that elastic, what do you call it? Is it class 2 or a class 3? Class 3. What's the shape of that elastic? Triangle. And I have two patterns, anterior triangle and posterior triangle. So I will call this anterior triangle class 3 elastic. So that pattern of elastics, especially that vertical component, will increase the incisal show while smiling. So you need anterior triangle class 3 elastics in your class 3 cases. At the end of this session, I may have time to share with you the patterns of elastics that I'm using. So I'm using the 4 tools in the case to control his class 3 mechanics. The same for the left buccal view, nothing special. And for the lower arch, we added tongue tamers. While you are doing your class 3 mechanics, you are still in the flexible wears. So it's fine to lose some of the torque, especially on lower incisors because they have very thin bones. Then later on, while you are increasing the size of the wire, then you are adding the tabs, you are controlling the lower incisors. We are rectifying the upper incisors, and we are correcting the inclination of lower incisors. So this is the before the treatment with the cross-bite and reverse overjet, and we are now in the finishing stage. I want to do overcorrection. All of that because I picked neutral torque for upper canines. So the neutral torque of upper canines in the class 3 cases will force you to finish your case in, let's say, overcorrected occlusion. All of that reflected on his cheeks. So we supported the cheekbone. He is not the best patient. He has a lot of bad habits. He's not cooperative with vitamin D, and he has a lot of carbs in his food. But for the incisal show, this is his incisal show before adding the tabs and the anterior triangle elastics. So I want to rotate his smile clockwise. So if you follow his smiling photograph, you see the rotation? Again. Let's see it again. We are doing rotation of the whole smile. We are increasing the incisal show for the eye. So by this, you have seen all the 4 tools for the unwanted forces of class 3 cases. What about constricted upper arch? Now this is the area of dental ultima. It has the power to give you the arch development. So we are not going to use conventional brackets or conventional vessel certification. Dental ultima will help you, and you remember the new design of dental ultima. all of that will help you to have kicking effect, shoulder to wall effect on your cases. And the most important wear is 14 by 12.75. So tell your patient that they will feel some tension, they need to rinse with cold water, to have some analgesics, and keep that wire minimum for 8 weeks. Don't rush to change the wire. This is one of the most wires. Keep it for 8 weeks, not less. That wire will give you rotation control, 98% of rotation control. This will give you the kicking effect. So all of you remember Kareem, and I told you that we'll cover his case 3 times, so this is the final time. And already his occlusal plane is upward rotated before applying any class 3 elastic. Most of your class 3 cases, they will have downward rotated occlusal plane, which is favorable. So once you apply class 3 elastics, they will have upward rotation. But already he came with upward rotation of the occlusal plane. So I need to correct the occlusal plane against my mechanics. And the maxilla is constricted. He is not in the country. He has to travel from Hungary. And these are the intraoral photos. And by the way, he was referred from orthographic surgeon. So the orthographic surgeon or the surgeon sent him to me to prepare him for orthographic surgery. So I told Kareem, just give me 6 months, then I'll send you back to the surgeon to convince him to avoid surgery. And he is so big, he is so tall, as you have seen yesterday. He is big. But he's totally cooperative, he's so kind, so kind. So this is the way of bonding with palatal plastic elastics. I'm going to change any torque. The upper canals, they should be neutral torque. We are using palatal plastic elastics. He has only one wisdom tooth on the right side. So I use that wisdom tooth for the demogram. But in the boundary position, I will send him to the surgeon to extract that tooth and to convince him that no need for surgery. So this is the day of bonding. This is the first wire, which is 14. Then I inserted the second wire, which is 18. Then I inserted the third wire, which is 14 by 27.5. Then he traveled back to Hungary. So we had that amount of change. I moved my degrammer to lower 2 centrals. I did the panorama. I sent him to extract 8. And applying now my mechanics to control the rotation of the occlusal plane. And in that severe malocclusion, I'm adding also another 2 tabs between 6 and 7, because the 3 mechanics together will rotate the occlusal plane. You see that from the buccal view. So if you check the mechanics for lower tabs, upper tabs, the classic elastics, the 3 of them, they will rotate the occlusion clockwise to correct the upward rotation occlusal plane. And we put the practice at 6, and we have the right torque. The same on the left side, nothing special on the left side. But the special view is the upper occlusal view. You remember, he has severe maxillary constriction. For most of us, you need surgery, surgically assisted expansion in such cases. But remember, sevens, they are the best preference for the art development. This is our third wire. At that time, he has to travel back to Hungary to complete his first semester. So he came back after 3 months. So this is the amount of art development in the 3 months. Please, if you have the chance, I need from all you just to hold the wire, which is 14 by 27.5. It's very soft wire. So that wire can help you if you have the right vitamin D level, calcium level, and if you leave that wire for minimum 8 weeks. We left it for 12 weeks, by the way. So the upper 7, they are the best support for your eye development. At that session, we inserted the second Ultima wire. Then now we are in the Sessi wires. Now we are in the finishing wires, and with Level Ultima, I have these residual spaces, accidental spaces. I didn't have these spaces before. So one of the tips, you can add power chain, duration 2 inch wide, under the wire between number 6 and 7, both sides. For the lower arch, again, nothing special except the deep murmur. We are in the finishing stage now with Kareem, and the same idea to prevent any accidental spacing between 6 and 7, and add the power chain under the wire. So from reverse overjet at the beginning, almost more than 3 millimeters. We are talking about 4 millimeters of reverse overjet. Now we are establishing positive overjet. The change in the lateral staff, this lateral staff was taken during the banner review before doing any, let's say, tags. So big change in 4 follow-up visits only. So this is Kareem before, and I'm planning to do debonding for him, I think this month or next month. He's about to do the debonding. And you remember his size and his height. So do you consider this, I mean the chin, throat distance, do you consider this too much? You remember him, big guy. This is normal. Imagine if you do surgery on the maxilla and the mandible, you'll shift him to a child profile. That's why I'm against surgery in males. So the classic cases, my way of thinking is different from males or females. Maybe in females, if this is big malocclusion, just because of the aesthetics, and I want to give females a class 2 profile, maybe I can propose surgery. But for Kareem, of course, we supported the mid-face just by the 4 tools, and we supported the transverse dimension by using our Ultima wires. So we restored the arch width just by wires. And we get rid of the gummy smile because the etiology behind the gummy smile was collapsed upper arch, like the umbrella. So remember this. You have challenges in the class 3, but at the same time you have benefits. I like class 3 mechanics because they will enhance the face, and also my feedback, my patients always they have better oxygenation. So class 3 is not bad. I mean in terms of mechanics, if you control it. If you open any textbook, I'll do my best to do that session before the lunchtime. If you open any textbook, what will be the location of Bimax cases? Are they with a class 1 or a class 2 or a class 3 or where? Always they will put the Bimax with the class 1. Where I put the Bimax? After class 3. Because for me, Bimax is a combined. Class 2 in the upper, class 3 in the lower. So if you can treat any severe class 2, and you can treat challenging class 3 cases, of course you can treat Bimax cases without, let's say, extraction, except for the wisdom teeth and I will delay their treatment because it's not functional treatment. I will delay their treatment to the age of 16 because of facial maturation and because of the AIDS. You know, the soft tissue support in that case, so you need to wait till the age of 16. So if this is your case, this is what I'm doing in biomass cases. I'm going to use TAD between tooth number 6 and 7 after extracting the AIDS to apply cluster mechanics in the upper. So that power chain will hold my buccal segment from canine to 7 distant. Then I'm going to apply this pattern of class 3 elastic. What do you call that elastic? Is it class 3? Yes. Triangle, but posterior. So we have anterior triangle class 3, and now this is posterior triangle class 3. To distalize the lower buccal segment. At the end, you will have space mesial to upper and lower canines, so you can do retraction. So this is what you are going to do in biomass cases. What will be the torque selection in such cases? It will be like class 1 with crowding. So this will be the torque selection. This will be the torque selection. High torque on the canines, because you are doing class 2 on the upper. So I want my canines buccal displaced. Class 3 in the lower, so I want my lower canines buccal displaced. So they can move. So I put procline torque on the upper and lower canines while I'm applying retrocline torque on the upper and lower incisors. But in some cases, you have compromisable retention. Like this case, she has Bimax, pathological drifting, but you don't have enough bone around the upper and lower incisors. So it's contraindicated to put retrocline torque for such case. So she has bone loss. So I put procline torque because of the period problem. But same mechanics, same mechanics. I mean, we'll add 2 tabs distal to upper sixes with posterior triangle class 3 elastics. So same mechanics. 2 tabs between tooth number 6 and 7. I'm doing retraction for the buccal segment. And I'm doing retraction for the lower buccal segment using posterior triangle class 3 elastics. All of that will give you a good amount of retraction, controlled retraction. So this is the profile of the same patient. He has mobile front teeth, bone loss, proclination. This is before the tags because I put procline torque. So I want to make the apices inside healthy medullary bone. Then I'm going to do controlled retraction, not proclination. So this will improve the bone around your incisors. And she was happy about the outcome. She told me that I changed her life. And she is the mother of Maya. You remember Maya? Maya, the other patient. They asked me to do debonding for her and her mother at the same day. She traveled all the way from Riyadh. So while I'm doing debonding for Maya, her mother was in the rest chair. This is compact eye touch from Grand Mecca. She was so happy, by the way. And everybody is asking them, Maya and her mother, why you are traveling from Riyadh to Jordan? Just to change the whale. This is so silly. Okay. But you can see the change in my and here profile. So we did the bonding for Amanati and Maya at the same session. And we took that one photograph for both of them. Okay. So thank you so much for giving me the chance to finish classic cases and biomass cases. Time now for lunch. We will have the remarks. After lunch,